Morning, everybody, and welcome to Grand Rounds this morning. So very pleased to introduce our co-faculty member, Dr. Lea Ann Chen. Dr. Chen actually grew up and raised in Oklahoma. She went to get her undergraduate education at Rice University, her MD degree at Washington University, and then went on for medicine residency at Mount Sinai, where her research at that point was recognized for a national award for resident research. Dr. Chen went on to GI fellowship at Johns Hopkins University, where I first met her. And in the course of her GI fellowship, she also worked in the laboratory of Dr. Cindy Sears, who was a world's expert in the microbial infections causing colitis. She then went on to NYU to become an assistant professor of medicine and continued her research development in inflammatory bowel disease under the mentorship of Dr. Marty Blaser. Of course, Dr. Marty Blaser is now with us, who is the head of the Center for Advanced Biotechnology and Medicine, CABM. And Dr. Chen has distinguished herself as a classic triple threat with an expert in inflammatory bowel disease and an educator. She is one of the co-course directors of the Crohn's Colitis Congress, a international, probably the top international meeting in education inflammatory bowel disease. And she's continued her research work on inflammatory bowel disease, intestinal microbiome, and C. difficile. She's on the editorial board of the IBD Journal. She's a counselor of the American Gastroenterology Association in immunology, microbiology, and inflammatory bowel disease. And she recently was awarded a K23 Career Development Award for her research work on development of therapies for microbial treatment of Crohn's disease. And very honored to have Lea Ann here with us at Robert Wood Johnson Gastroenterology. She came in September, is distinguishing herself as an IBD clinician, as an investigator. So welcome, Lea Ann.
Thank you, Steve. It was a very kind introduction. Let me share my screen with everybody. Let's see if this works. All right, give me just a second here. Trying to do an advanced maneuver. I'm not sure if it's working.
You're very warm.
Getting there?
You're
Almost
getting
there.
Almost there.
Right.
Really warm.
Now?
Really warm.
There we go.
You're hot.
All right. Okay, thanks everyone for bearing with me. So thank you for coming to my talk today. We're going to be discussing microbiome manipulation in the treatment of inflammatory bowel disease. As Dr. Brantz mentioned, this is an area that's of both research and clinical interest to me, and I'm happy to share this with you today. Here are my disclosures, none of which I think are relevant for today's talk. Today, I'm going to be going over three main objectives. First, I wanted to discuss with you guys the key studies demonstrating causal link between microbiome changes and IBD activity. And then I wanted to move into interpreting the data for some of the emerging studies that we see about IBD and fecal microbiota transplantation, or FMT. And then finally, I'll wrap up briefly with just some practical tips for how we counsel our patients who are interested in microbiota-based therapies, as they become more popular, in the lay press and public. So we got to start Medicine Grand Rounds with a case, right? And this is one that I actually think back to often, this was a gentleman that was seen back when I was a fourth year medical student. I was on my GI elective, and at that point I was thinking, oh, maybe I want to do GI and maybe I want to do IBD. And so I was in IBD clinic, and the fellow, comes out from seeing this patient and presents the case. It's a guy in his 30s. He's had ulcerative colitis for many years. And he has, all the typical symptoms of active disease. So he has bloody diarrhea and abdominal pain. He's had some weight loss, and he's been taking the maximum dose of mesalamine. So he's getting 4.8 grams orally each day, and also rectal mesalamine enemas. And he's still having these symptoms and is not, responding. And so at that point, the recommendation was to start, was to step up therapy to an immunomodulator and a biologic, and the patient didn't want this. He said that he didn't want these medicines. He was going to catch a flight to Australia. He was going to get a fecal transplant. And granted, this was, I don't want to date myself, but a 15-ish years ago. And kind of cringe thinking about it, but we, laughed. We thought this is ridiculous, that this person is he doesn't want the medicines we want to prescribe. He's gonna go to a foreign country and let somebody do a fecal transplant on him. And kind of little did we appreciate at that time, but the patient and our medical colleagues in Australia were onto something very interesting about the microbiome and IBD. So just a brief overview. There are multiple diagnoses that fall within IBD, but the two predominant subtypes are Crohn's disease and ulcerative colitis. They're both characterized by this, chronic intestinal inflammation that waxes and wanes. Crohn's disease in particular can affect any part of the GI tract, including the small intestines and the upper GI tract. And it can present as these skip lesions, and the inflammation is transmural. Whereas in ulcerative colitis, the disease starts in the rectum and it can move proximally and encompass the whole colon, but it doesn't affect the small bowel. And for both of these conditions, we don't fully understand what the cause of the disease is. It's not that these are new diseases. Actually, if you're into reading, historical medical literature, you may find that Crohn's-like cases were being described by the German surgeon William Fabry back in the 1600s. And then in the mid to late 1800s, there were similar anatomic reports and textbooks describing a non-infectious inflammation of the intestines, with the first, case report type presentation being presented by Dr. Samuel Wilkes and Walter Moxon, both Englishmen. But then you can see that, for many years, there really wasn't much going on in the field of IBD. And it was only in the past, perhaps, 70, 80 years where there was really dedicated study into the treatment of inflammatory bowel disease. And so, you can see early on, there were studies, looking at thiopurines and mesalamines. And our first biologic, infliximab, was approved in 1998. And then, it was another almost, a decade and a half before, we had any other new mechanism of action. And it's really been in the past, 10 years that we've seen a few more options that we have to treat this, lifelong or chronic disease. But the unfortunate part of, essentially all of our IBD therapies is that they work through, host immune modulation. And this kind of demonstrates, all of the finesse of, maybe a whack-a-mole game. So we see that, TNF goes up, and so we give something to make the TNF go down. And we see that, IL-23 goes up in intestinal inflammation, and so, we give a medicine to make that go down. Or we have, biologics that inhibit leukocyte trafficking. So the inflammatory cells can't get into the target tissue, but again, all of this immune suppression comes at a price. And so the adverse effects of, many of our IBD treatments are infections, atypical infections, and malignancies. And a lot of patients aren't, happy about that. And that's why they're seeking other types of therapies. So this kind of brings me to the concept of an origin, story. So, if you're a comic book fan, you know that this is the backstory or the established backdrop, that really informs the identity or the motivations, of a character. So, why Superman is susceptible to kryptonite, and, who's Darth Vader, etc. And not to anthropomorphize, IBD too much, but one can certainly expect that if we understood more about the pathophysiology, we would probably be better at understanding why there are these different types. Why is there ulcerative colitis and it looks that way, and why is Crohn's disease different? Why do some patients respond and others don't? And what is its weakness? How can we treat IBD in a better manner than with the therapies that we have available today? So looking into the pathophysiology of the disease, we know that there's definitely a genetic component, and that's one aspect of the risk. Large genome-wide association studies, which are studies that Dr. Brandt, and his colleagues have worked on, have really taught us a lot about IBD. So, for instance, we know that there are a lot of different variants that are associated with IBD risk, and most contribute only incrementally to the disease. And so you really have to look at one's kind of composite genetic profile in terms of all these variants to get a understanding of one's overall genetic risk. Also, we know that there are some genetic variants that are specific to Crohn's disease, and some that, are predisposed to ulcerative colitis, but then a number of them are shared, between these two conditions. And then if we look at the functions, of the known functions of some of the genes identified, we do see some commonalities that are really interesting. So for example, a number of these variants are located in genes that, impact immune functions, so how the host interacts with different bugs, their environment. A number of them also relate to autophagy, and the cellular processes by which the body senses and degrades certain substances. And then other groups have to do with epithelial barrier integrity. And so, tight junctions and other proteins that are important in kind of creating the physical barrier between, us and not us. And then another way to understand, the genetics and the inheritance of these risks is through twin studies. And luckily, there have been some fairly large ones in IBD, which have been really informative, and also pretty impressive in terms of how precise the results have been. And so these are some studies from Sweden, Denmark, and the UK. These are countries we'll come back to because they're really good at these kind of population studies. But this looks at concordance rate for Crohn's disease in, monozygotic versus dizygotic twins. And so looking first at these non-identical twins, you can see that the concordance rate between, the twins varies between 0 and 7% for both Crohn's disease and ulcerative colitis. So, not that high. If you have a twin that has IBD, then, you most likely are not going to get it as well. If you look at the identical twins, you can see that for ulcerative colitis, the values range from about 15 to 20%. And for Crohn's disease, the concordance is about 20 to 50%. And so, this is really interesting in that it shows us that Crohn's disease, probably has a greater role for genetics. And that furthermore, there's something besides genetics clearly that plays a role in IBD risk, because even among, identical twins, at best, you're getting, 50% concordance. So this is, a world map looking at IBD prevalence. And so, one of the things I mentioned to you is that the pace of kind of the development of IBD treatments is picking up, but that's really not the only thing that's been gaining speed. I would say one of the most interesting aspects of IBD and studying IBD is studying how it's spread and it's spreading globally. And so, as I mentioned before, it was a disease that was initially described in Europe. It was seen, predominantly in Western and Northern Europe, also the United States and Canada. But over the past several decades, it's popping up in countries, all over the world, and in areas where there was previously low prevalence. Now we're seeing more and more IBD. And so this map in particular here shows you the age standardized prevalence in 2017. And so you can see that, parts of Eastern Europe, New Zealand, Asia, Russia, these are really areas that were previously, low prevalence that are now starting to approach the prevalence, of Western Europe and North America. Furthermore, the incidence has been increasing globally, and perhaps even more so in these previously low prevalence countries. So you can see areas here in Central America, a good portion of Africa, again, in Asia, and then, these islands in Oceania. I'm not sure what's going on, but their, rates are skyrocketing. And these are countries where their prevalence has increased, over 100% in the past 30 years, which is pretty scary. And the other thing it tells us is that, genes don't change at this pace. And so, again, there's something in the environment that's really impacting IBD risk. And so, this is just a synopsis of, kind of the current understanding is that clearly, the risk for IBD development lies at this intersection between environment and genetics. And if we had to pick one, then the environment probably plays a greater role in disease development. And that might be good news. So, I just showed you the map where the world's on fire and everyone's getting IBD, and that sounds really bad, and it is. But the silver lining is that this pace of change, it means that this risk is mediated by environmental factors, and environmental factors are modifiable. So, if your goal is to alter IBD risk, to prevent IBD, then the factors you can influence are probably going to be the environmental ones instead of the genetic ones. What are some of these environmental risk factors? There have been a number of epidemiological studies that have shown multiple variables at play. Actually, one of the strongest influencers of IBD activity is smoking. So smoking consistently makes Crohn's disease worse. So this has been shown in studies, time and time again. And, it makes the disease more aggressive, more difficult to treat, whereas it's actually slightly opposite in UC. So smoking in UC is somewhat protective. Also, a number of studies have looked at diet, and particularly fiber intake in children, and it's shown that those who eat a high fiber diet are at decreased risk of IBD, later on in life. And then there have been a number of medications that have been associated with IBD risk, including NSAID medications and also certain hormonal therapies. And of course, one of the most interesting things is that for all of these various influencers, they've all been shown to correlate, with the gut microbiome as well. And so, speaking in hypotheses, it's possible that your gut microbiota is really the ultimate effector by which all these various environmental contributors compositely impart their risk of disease. And so one of the easiest ways that we know of to manipulate the microbiome is through antibiotics. And so how does antibiotics impact IBD risk? Well, this is a study out of the UK. It's a big study, well done, looking at the years between 1994 and 2009. And so they essentially took, everybody in their national health system and looked at, children who were given antibiotics. They excluded kids that didn't have follow-up or who had follow-up for less than 2 years, and then those who had, had already developed IBD, but otherwise, everybody else was included. And so there was over 1 million subjects. It was 6.6 million person years of follow-up. And during this time period, 748 individuals developed IBD. And so you can see that starting around age 5, you're getting a little bit of differentiation between these two curves. And so you're starting to see that IBD exposure, is associated with a greater risk for IBD. And if you look at the number of courses of antibiotics, and whether or not that impacts risk, it's a little bit scary in that, just 1 to 2 antibiotic courses significantly increases your risk. And so the red line here is greater than 2 courses, and the yellow line is 1 to 2 courses, and they're not that different compared to the unexposed cohort. And then finally, they looked at the age when individuals had their exposures. And so you can see the earlier on the antibiotics were given in life, the greater the risk for IBD is. And so these results have been replicated in the Danish studies and the Swedish studies. And these are all, very large cohorts. Similar findings, though to a much smaller degree, have been found in adult populations as well. But certainly the effect is most prominent in kids. But these studies are epidemiological cohorts, they're correlative, and they don't really tell you whether or not the IBDs, the antibiotics cause the IBD. And so this is where animal studies can be really helpful. And there are a number of animal models for inflammatory bowel disease. A number of them are chemically induced colitis, but there are a couple that are microbiome dependent. One of them is the IL-10 knockout model, which is a really interesting model in that, the IL-10 gene is also implicated in human IBD. When you look at the GWAS studies, variants in IL-10 are some of the variants that have the strongest impact in terms of disease risk. In children, there's IL-10 mutations that can cause, very early onset IBD. And so, from a genetic standpoint, it certainly has its correlations with human IBD. And then also in this particular mouse model, its disease is microbially dependent as well. And so if you keep these mice in a germ-free or notobiotic facility, they never develop intestinal inflammation. But if you conventionalize them, then they will spontaneously develop intestinal inflammation. And so this is a study looking at how different antibiotics impact disease development in this IL-10 knockout model. And there's, two strategies. As I mentioned before, these mice will spontaneously develop disease. And so you can use a prevention strategy where you're giving the antibiotics, before any disease develops, or you can use a treatment strategy in which, these mice were given antibiotics after development of inflammation. And you can see in both strategies that giving antibiotics actually improves the histologic inflammation and decreases the inflammatory tissue cytokines. They were looking specifically at IL-12 and IL-1 beta. And you can also see that, different antibiotic regimens have differential impacts. And so across all the groups, you can see that this vancomycin-imipenem combination was the most impactful in terms of decreasing the inflammation and the inflammatory burden, whereas the effect was a little bit more similar with ciprofloxacin and metronidazole. But the interesting thing, or kind of maybe the confusing thing about, this mouse study is that here the antibiotics actually is improving, the inflammation. And these are, mice that are a little bit older. And so what happens, in an animal model that probably more closely approximates the cohort studies, the epidemiological cohort studies I was talking to you about earlier. So this is a set of experiments that came out of the Blazer lab in 2018. It was published in Nature Microbiology. And what's really interesting in these studies is that they not only used germ-free mice, but they used pregnant germ-free mice. And so they created two pools of donor stool. All right, so they had wild-type mice, and some of them they just treated with water, and some of them they treated with antibiotics. And so you have the antibiotic-perturbed microbiota, and then you have just the regular, fecal microbiota. And then they had two groups of germ-free mice. They had just the wild-type germ-free mice, and then they had the IL-10 knockout germ-free mice. And again, these are pregnant dams, all right? And so they gavage the control microbiota and the antibiotic-perturbed microbiota into these germ-free mice, and then these mice, give birth to pups, and then they follow what happens in the intestinal inflammation of these pups. And one of the things that's so clever about this study is that we know that exposure to microbial communities is important for the normal development of your immune system. So one of the criticisms of using germ-free mice, even though they're incredibly helpful for studying specific microbial communities, is that they may not really have a normal immune system because of their germ-free upbringing. And so this study kind of gets around that particular issue. And what they found was that in the IL-10 knockout mice who received the antibiotic-perturbed microbiota, they had a very significant increase in the amount of intestinal inflammation. So this is, these two top panels are the wild-type mice. This is the control, this first column here. The second column is the mice that were born to germ-free moms that had the antibiotic-perturbed microbiota. And so, you can see in the wild-type mice, there's not a really significant difference, but in the IL-10 knockout mice that, over time, the intestinal inflammation really gets very severe compared to the control microbiota. And so, this study demonstrates that, one, the genetics, is an important part, having that IL-10 deficiency, but then also the inheritance of a dysbiotic or altered microbiome plays a role in the intestinal inflammation that develops later on. And potentially that the timing of this exposure to the perturbed microbiota might make a difference. Now, in terms of human studies, there have also been antibiotic treatment studies in humans, and perhaps one of the areas where antibiotics is used clinically in IBD or studied clinically in IBD is in the case of Crohn's disease. So Crohn's disease patients who get surgery for medically refractory disease many times will develop disease again over time. And there have been a couple of studies looking at nitromidazoles, which are class of antibiotics as a way to delay or prevent post-op recurrence. And so these were studies led by Paul Rutgers, who I wanted to acknowledge. Dr. Rutgers actually passed away in September of this past year. I never met him, but I've certainly learned a lot from his studies, and he's clearly a loss to our community. But he was the first author on these studies looking at metronidazole and ornitazole, which is not available in the US. But in both studies, he and his colleagues showed that they could decrease the rate of endoscopic recurrence significantly, about 25 to 30% at 3 months, giving patients, metronidazole or netromidazoles following their surgery. The issue is, though, patients have a hard time tolerating, being on these long-term, antibiotics. But it's very interesting in terms of a proof of concept. There have been a number of other studies looking at antibiotics as treatment of inflammatory bowel disease, not looking at prevention, but just, treatment of the disease. They've been very heterogeneous because they've looked at a whole bunch of different types of antimicrobials and a number of varying IBD populations. And so, combined, this makes it difficult to interpret. And so here, some meta-analyses have been helpful or have tried to address this issue. And so I'm showing you the data from a meta-analysis published in 2011, looking at the use of antibiotics for treatment of active Crohn's disease. And this is probably the area where there's been the most literature. And so you can see that, on the whole, there are quite a few studies where the relative risk crosses 1, but there are, a number of studies where there may be some benefit. And if you look at the combined data, it seems like there may be some benefit for use of antibiotics, but even if so, the benefit is very, very modest. So, besides antibiotics, there are potentially some other ways of manipulating the microbiome, and that is through surgery or fecal stream diversion. And so, again, this is Dr. Rutgers' work and his colleagues in Europe. And what they did was they studied patients who were getting surgeries. So they were getting ileocectomy, so the cecum and probably the last end of the terminal ileum was being removed because of medically refractory disease or strictures. And in a portion, a subset of patients, what they did was they went upstream into the small intestine and created a diverting ileostomy. So here, the stool is going to come out here, and it's not actually going to enter in, the rest of the terminal ileum and colon. And then, of course, in the other group, they had primary anastomosis and they were reconnected immediately. And so what they noticed was that there was early recurrence in the terminal ileum for patients who were not diverted. And so, that contact with the fecal stream was associated with early recurrence of disease. And if you diverted that fecal stream, then those patients did not have endoscopic recurrence. And this is a similar study looking at perianal disease. So, instead of the small bowel, we have a number of Crohn's patients that really suffer from having, fistulas and abscesses in the anal region. And so fecal stream diversion in this situation has been studied as a way of, trying to alleviate the disease in that region in patients who've been, medically refractory or challenging to treat. And so there have been a couple of studies. This is one published in a surgery journal. It looked at 31 patients who were getting fecal diversion for their perianal Crohn's disease. You can see that there's 81% early remission, which is why this is even, considered, is because a significant number of patients do go into remission. But of those, 17, or about 55% of the total population relapsed within 2 years. And then 26% of the total patient population continued to have remission, but only 10% could actually be reanastomosed successfully. And so if you look at, the overall population, very few are able to be successfully reanastomosed following their diversion. This is a similar study from the Boston group, looking at it, same question in a slightly different way. So they looked at 49 patients who were similarly getting their diversion for perianal Crohn's. Of them, about 70% remained diverted, and 30% had a reanastomosis. In these patients, 10 of them had to be diverted again, essentially failed reanastomosis. Only 10% of the total population could remain in continuity, and of those, about half of those still required some type of procedure for pelvic sepsis. So overall, a very low success rate. And so, I think what's particularly interesting is, proof of concept that something in the fecal stream is contributing to disease activity, but in terms of a management tool, not very successful in terms of being able to treat the disease long-term, sometimes helpful as a way to help your patient adjust to the concept of, having a pouch. So in the end, are we anti or probiotics? It's a little bit hard to tell. The data are a little bit unclear of how antibiotics or microbiome manipulation impacts IBD. I think the main point is that clearly there's a relationship. And this has been shown in multiple human studies and animal studies. But what we don't know is how to rationally manipulate the microbiome in a way that's clinically meaningful. Despite not knowing the pathophysiology, it's incredibly important that we talk to our patients about it. And so this is a study published from a cohort of Mediterranean IBD centers. They were studying their female IBD patients by survey, and we're asking them about, their opinions or their fears about passing on IBD and pregnancy and family planning. And what they found was that those who had counseling regarding this, that was associated with increased pregnancy rates and decreased voluntary childlessness. And so there was actually a significant portion of their surveyed group who voluntarily were not having kids because they were worried that about the genetic risks of IBD, and that either the disease and or the treatments would be harmful to their newborn. This actually also reminds me of a patient that I saw, a male patient in my own IBD clinic who I had known for a couple of years. I think it was just during a regular med reconciliation part, he asked me if I thought that his IBD treatments caused his son to have Down syndrome. And I was shocked that he had thought this, and I felt horrible because I don't know if that was just something he had, in his mind that day, or if he had really, had this guilt or fear for years that he was somehow, responsible, for his son's condition. And so, again, even if your patient, even if you're not talking to your patient about it, your patient is thinking about it. So it's probably helpful just to, provide them that information about what we do and don't know about pathogenesis. So now I just wanted to talk about FMTs because this is gaining more and more attention in the past decade. So even though it's accepted in modern clinical practice and it's made its way into, our society guidelines, there's actually no FDA approved indication for fecal transplant. It is used for C. difficile infections clinically. But and that's based on just kind of a preponderance of anecdotal data that it works. But if you look at the only double-blind randomized clinical trial that we have of FMT, it was actually a negative study. And so it was 2 sites. One site, there was a significant difference between donor FMT and autologous FMT, which is just the person storing their own stool and then being blinded when they're getting fecal transplant with essentially their own stool. So there was a difference between real and placebo FMT in the Rhode Island site, but not in the New York site. And so overall, it was a negative study. Again, this is for C. diff. This is not for IBD. So there have been now 4 randomized clinical trials looking at fecal microbiota transplantation for ulcerative colitis that have been published. The first 2 came out in the same issue of Gastroenterology in 2015. And so in this one, they looked at 50 UC patients that had mild to moderate disease. They had endoscopically confirmed disease. And these patients were given their fecal transplants by a nasoduodenal tube twice. At the beginning of the study and then at 3 weeks. And then they had a endoscopy at 12 weeks. And they noticed that even though there was some improvement that, both in the intention to treat population and the per protocol population, that there was no significant difference. And so actually this study was terminated early due to futility. What the authors did want to note was that, when they looked at their clinical responders versus non-responders, they noticed that in the responders, in both groups, actually, even the placebo FMT, that there was an increase in microbiome diversity, compared to the non-responders who seem to not really have any significant change in their diversity. So suggesting that it's possible that, FMT could be successful, but we, don't quite know how to use it yet. In the same issue, there was a positive study that was published. This looked at 75 UC patients, again with, mild to moderately active disease and confirmed endoscopic disease. And here they did find a difference between FMT and placebo, but interestingly enough, all the other, secondary endpoints that you thought would have correlated were not statistically significant. So, a clinical response, quality of life, C-reactive protein, these were all not different between the groups. Another interesting part about this study was that this study too was actually marked for early termination for futility. And so, when they started the study, they had 2 patients go into remission using one particular donor stool. It's called donor B. And then from April to November, there were a number of different donors that contributed, and 2 patients went into remission, one from E and one from F. And I think at some point, donor B was out of commission for some reason. There was a reason why donor B couldn't participate during this time. And so soon thereafter, their data safety monitoring team said, look, this is not going to be a positive study. We're going to terminate it early, but you can complete the protocol for all the patients that have already enrolled. And so in those last few patients, they all got donor B stool and 5 patients went into remission. And so that's what turned it into a positive study. And so, there's this question of whether or not there's these super donors or, particularly, particularly good donors for FMTs for IBD and we just simply don't understand yet, what that super factor is. For the sake of time, I'll probably just skim this one. So this is one of the Australian studies looking at UC again. And what I'll note here is that their protocol was FMT by colonoscopy. They did enemas 5 times a week for 8 weeks. And they found a difference between, treatment versus placebo. And this is the most recent FMT study for UC. This was published in 2019, also out of Australia. And here, again, the patients had FMT by colonoscopy, and then they had 2 enemas that were delivered, within 7 days, and then they were scoped at 8 weeks. And so, again, a positive study, you can see that those who got true, FMT had a much more, were much more likely to have a symptom improvement compared to those who had, sham FMT. And so one of the things that you might have noticed between that first negative study and the other studies was the intensity of the FMT. And how often it was given, how much was given. And so that's certainly something that's different between FMT for C. difficile infections, in which 1 or 2 treatments is enough for 80 to 90% of patients to respond, versus in IBD studies, where it seems like a more intensive or chronic regimen may be important. So this is a study that we did with collaborators at Hopkins, looking at FMT in children for C. diff indications, though some of these kids had IBD and some didn't. And so what we noticed was that, prior to the FMT, in both groups, the microbiome diversity was low compared to donor. And, all patients got their FMT. They all had successful FMTs. Everybody responded. But you can see at 6 months, after the procedure, the IBD negative patients continued to have, a restored microbiome diversity, on par, maybe slightly, elevated compared to donors. But the IBD positive patients, even though they didn't have any recurrence of their C. diff, their microbiome has already gone down back to, their pre-treatment baseline. And so, again, suggesting that, IBD is a chronic state, and the way that we give FMT for IBD might need to be altered compared to, the way that we give it for C. diff. One study for Crohn's disease so far is a pilot study. It was very small, 17 patients. Unfortunately, a negative study, though there were a number of things that suggested that it might be a positive study with more patients. And so I think they're completing this trial now. This was just published fairly recently. So, in terms of microbial manipulation, are we there yet? Again, I think, there's a lot of really interesting preclinical data. There's a lot of interesting clinical data and experience to suggest that microbiome manipulation can play a role in disease, but we certainly don't have the level of evidence that we typically have for our IBD treatments in terms of how to use this therapy. Nonetheless, we have patients who are really, really interested in microbiome manipulation. And so, they read these miracle studies where somebody had an FMT and they were cured, or they're on probiotics. And so, we get a lot of patients who come in, asking for our advice or, asking for these types of therapies. So, I wanted to address this just very briefly in our remaining time and kind of how I personally approach this issue, given kind of the heterogeneity or lack of data that we have. So one issue is that, oftentimes we'll hear, and this applies to physicians too. They'll say, I prescribed the patient a probiotic, or I recommended a probiotic, or the patient says, I take a probiotic. That's equivalent, saying, I take a medicine. It's a very, very broad term because there are, a multitude of different types of probiotics. They come in different doses. They have different properties. And we shouldn't really expect that they all work in the same way. And part of the problem of research in probiotics is that it's so heterogeneous. There are multiple small studies, multiple different types of probiotics at different doses. So it's very, very hard to make any sense of the data. Not to say that there isn't anything promising there, but it's very hard to to provide good medical advice to patients wanting to know more about how to use probiotic therapy. And so I think one way to change at least the culture of how we think about probiotics is really thinking of them, as we would a medicine, where we think about, the type, the strain, and the dose that's used. And so, the probiotics that you'll see are typically those that are lactobacilli and bifidobacteria, and then of the fungal ones, it's the Saccharomyces. But it's important to note that even on the strain level, it's really important, what type of probiotic something is. So we know that E. coli is in, all of our guts. We know that one particular subtype, 0157 can cause, disease, can cause renal failure. And then this other kind, E. coli Nissl, is marketed as a probiotic. And so this strain actually was cultured from a German soldier, and his whole unit had come down with dysentery and he didn't get it. And so they wanted to find out, like what was interesting in his stool, and they got this E. coli Nissl strain that's been positive in a few small studies in terms of, preventing disease or helping symptoms. So it's just a reminder that we have to be very, very specific when we're talking about probiotics, because they, even the same species, the subtypes can do different things. So here is just the Cochrane, the most recent Cochrane review, looking at the use of different probiotics for IBD. Here in ulcerative colitis, here in Crohn's disease, the short version is there's either insufficient data or no improvement seen in these studies to date. There are some signals that probiotics could be helpful in palchitis. So for patients who have ulcerative colitis, who've had a colectomy and have had, the distal part of their small bowel turned into a pouch to serve as a rectum, that pouch can get inflamed. And there have been a couple of studies suggesting that one, standard antibiotics can be helpful, but in chronic pouchitis and in pouchitis prevention, there have been some positive studies looking at this particular brand, VSL number 3, that have been positive. Of note, there's a formulation change in this. There was some lawsuit disagreement between the inventor and the company. And so actually the VSL3 that is being sold today is not the same compound as what was studied in these original studies. So it's different. The original inventor is now marketing his original probiotics as Visbiome. And so just wanted to share that. So I'm not sure everyone is aware of that. And then actually the American Gastroenterological Association recently published their own guidelines on probiotic use. This is just their recommendations as it relates to inflammatory bowel disease, and essentially the same thing. There's really no recommendation in terms of Crohn's disease and ulcerative colitis, and there's very low conditional data for use of probiotics in pouchitis. And if you do, they do suggest, that original VSL number 3 brand, which is now whatever the Visbiome. And they said, if for cost or feasibility or whatever, it's not reasonable, then you could very reasonably just not give any probiotic as well. So in summary, what can we do in terms of practical tips? I have a lot of patients who come in, they really want to have a fecal transplant for their IBD or for their IBS or for something that's not C. diff. So I try to enforce to them that, legally, I'm not allowed to do this. There's no FDA approval for fecal transplants for anything, including C. diff, but the FDA is providing some enforcement discretion regarding the C. diff indication. And so I will oftentimes go to clinicaltrials.gov with the patients and help them, look for clinical trials to enroll in. And this is helpful because now the patient will be in a study where they're being rigorously monitored. And also it's going to contribute to, our global knowledge of whether or not this therapy is even useful for, the particular indication of interest. In terms of FMT registries, there is a national registry that the American Gastroenterological Association is spearheading. We will be hopefully a participant in that registry as well. But then again, this is an effort to collect long-term data about safety for some of these compounds. And then finally, just continue to monitor the literature. There's so much interest these days in the microbiome and microbiome manipulation and inflammatory bowel disease. And so there's a lot being published. It's actually quite difficult to keep track of, all the studies that are being published. But there's plenty to stay tuned about. And then, the final tip that I kind of give my patients is that, we're really at the border between what we know and what we don't know. And sometimes, interest kind of outpaces the science, and their personal observations about how they feel regarding a particular diet or microbiome may be completely valid. It's just that I don't have the level of data, the rigor of data that we would expect for any other FDA approved product for some of these things. And then, final note, and again, thinking back onto the patient I presented, is just remembering there's a lot of humility in medicine. And sometimes, the things that patients say to us that we think, don't make sense or we describe as crazy, can actually be really insightful. And so there's always a lot to learn. I'm happy to take any questions.
Yeah, Lea Ann, thank you. That was fantastic. There's a few questions and comments coming through. So Dr. Brandt, I don't know if you wanted to start out.
Sure. Yeah, great talk. Enjoyed it, Lea Ann. So currently for Crohn's disease, are you currently recommending metronidazole postoperatively, or are there any antibiotics that you're routinely using in Crohn's disease or your go-to for patients that request?
I wouldn't use it regularly just because I wouldn't be able to keep a patient on it. I think, there are some patients where they either don't want to be on a biologic, they merit some type of treatment for prevention afterwards and don't want it and are willing to take an antibiotic, in which case I would consider it, or patients, that are kind of in these very specific scenarios where I would consider it, but I don't use it for everyone routinely, though I do believe it works. I think if the data has been clear that it does decrease the risk of endoscopic recurrence. It's just that it's not really a feasible strategy long term.
Okay, great. Ankit Shah, did you want to ask a question?
Sure. Lea Ann, can you hear me?
Yeah. Can you
A great talk. So you mentioned in your talk that high fiber diet is somewhat protective for the development of IBD. Do you know, is there data on the introduction of highly processed foods, Western diet, particularly in developing countries or even intake in developed countries, if that plays any role in the pathogenesis of IBD, and if this is related through the microbiome or some other mechanisms?
Yeah, so there have been some recent diet studies. I don't know that they've looked particularly at processing of food. I know that they've looked at things like Mediterranean diet, et cetera, for, treatment, IBD treatment. But I don't know of any that have looked at it in terms of disease risk.
All right. And Renita, I don't know if you wanted to ask yourself, or I can ask the question that you had.
Yeah, go ahead. I can ask
Okay.
it. Yeah.
Yeah, go for it. Yeah.
Again, thank you. Is there any data that has looked at the microbiome differences between parts of the world where there's low prevalence IBD versus higher prevalence IBD?
So there are some studies, but I don't know that they've been the same studies, if you know what I mean. So comparing, within one cohort. I know that so for example, Maria Gloria Dominguez here at Rutgers now, she's been a part of of studies looking at microbiome diversity and different cultures, including those that, are indigenous, versus those that are westernized, not specific to IBD, but, just in general. And clearly there's been data to show that, indigenous cultures have much higher microbiome diversity than industrialized cultures.
Thanks.
Wonderful. Great. Thank you. Lea Ann, it was a fantastic talk, insightful and really educational, and lots of great takeaways for our patients too. So thank you very much. And reminder to everybody that next week is our first annual Sodani Women in Medicine Symposium. So for that, there will be a grand rounds at the typical time from 8 to 9 in the morning. And then there will be a session in the evening with multiple speakers and a Q&A roundtable session. So thank you all. Have a great week.